valves, the coronary circulation, the conduction system, followed by the cardiac valves, and finally just a few slides on the pericardium and great vessels. So that's the sort of an overview of what I'm hoping to impart on you. I'll be going through some of the slides relatively quickly because I think a lot of you will know this information, but I thought it was important to have this basis of the presentation that you'll be of the talks that you'll be receiving later today. So to start off, the mediastinum is broken up into a superior mediastinum above the plane of Lewy and an inferior mediastinum, which is further subdivided into the anterior, middle, and posterior mediastinum. What divides the anterior, middle, and posterior mediastinum is the pericardial cavity, and it is obviously the structures within the pericardial cavity that we'll be focusing on today. The plane of Lewy, which divides the superior and inferior mediastinum, is an important anatomical landmark because it helps us define where different structures are. And on the plane of Lewy, that's where the manubriosternal joint is, it's where the second costal cartilage is, it's where the inferior border of the fourth thoracic vertebrae is, but also within the mediastinum, it's where different structures exist. So the inferior aspect of the aortic arch is where the bifurcation of the pulmonary artery occurs, where the cardiac plexus lies, where the trachea bifurcates, where the azygous vein crosses from right to left. So it's an important landmark for us to find different anatomical structures within the thoracic cavity. And importantly, it allows us to define where the structures that lie within the pericardium cavity, i.e. the middle mediastinum. This is a more in-depth anatomical diagram that shows you with the chest wall having removed where the different structures are. So the plane of Lewy will lie somewhere around here, and then you've got the inferior mediastinum, which has got the pericardial sac, and within the pericardial sac is the middle mediastinum and the majority of the cardiac structures. This is to try and relate some of the anatomical description that I've given you to what we see in the operating room. So having performed a median stenotomy on the picture on the left side, you will then see you will then reach the inferior and the superior mediastinum. And in the inferior mediastinum, we have some of these structures within the anterior mediastinum. You have the pericardium itself, which you can see being opened by the diathermy and held apart by the two forceps. And then within the middle mediastinum is obviously the cardiac structures and the heart. The first structure that you come to is usually the right ventricle. That is because although the right cardiac structures were on the right side, embryologically, during embryological growth, they rotated. So some of the right structures rotated to the front, and some of the left structures, the left ventricle and particularly the left atrium, rotated to the back. So structures that you come across when you first open the pericardium, and also when you encounter cardiac trauma and stabbing, is the right ventricle is the most anterior structure encountered. So to move on to the bulk of the presentation today, I want to talk about the cardiac structures, where the heart lies. These are the anatomical landmarks of where the heart is when you see it from the outside. So the right cardiac border is just off the right sternal edge and goes from the second to about the fifth intercostal space, across to the fifth intercostal space, close to the mid-clavicular line and where the nipple lies on the right, and up again to the second and third intercostal spaces further up on the left cardiac border. And we can see these different structures on a chest X-ray, which is why it's important to appreciate where the cardiac borders are, because if you get different chamber enlargements, such as the right atrium or the left ventricle, they will obviously displace the cardiac borders on either side. So moving further on, once you take away the pericardial, once you get down to the mediastinum, you get to the pericardium. The pericardium itself is made up of different structures. So you've got the fibrous pericardium, which is the outer layer, and then you've got the serous pericardium, which consists of the parietal outer layer of the serous pericardium and the inner visceral layer. So, and it's between the serous pericardium, between the visceral and parietal layers, is where the pericardial fluid lies and where you can get pericardial effusions. And again, it's important to get an understanding of that because of the appreciation of the different clinical conditions that will arise, and we'll talk about some of them later. So taking the heart down to a structure, a level further down, we look at some of the cardiac structures themselves. Got the right atrium, as I mentioned, embryologically, although the right atrium is still on the right, it has rotated a little bit to the heart due to embryological rotation. And we can see how blood flows from the right atrium into the right ventricle. And similarly, left ventricular flow comes into the left ventricle and then out into the aorta, which lies behind the pulmonary artery. And it's understanding this embryological rotation will give us an idea where these different structures are, which are obviously important when we move on to operating on them. Taking the cardiac structures down to another level, we can now see the coronary arteries, which lie on the epicardial surface of the heart. As I'll be showing you the coronary arteries later, you'll see that majority of the major coronary arteries lie in grooves or sulci within the cardiac structures. So the right coronary artery here, we can see lying in the right atrioventricular groove, the left anterior descending artery lying in the anterior interventricular groove between the two arteries. But we'll go on to talk about those in a little bit more detail. But here we can see the coronary circulation. If we take the heart down to a further level, we can then see the valvular structures within the heart. We can see the aortic valve in the middle of the four valves, surrounded by the tricuspid valve, the mitral valve, and the pulmonary valve. And we'll go on to talk about the different valvular leaflets and structures associated with them. Taking the heart down to a further level, we can see the different walls that separate the left and right heart circulations, which are obviously important for oxygenated and deoxygenated blood to be streamed in the appropriate direction. So here we can see the ventricular septum, the thick muscular part, and then also the membranous septum, which is a lot thinner and which is important, again, to understand the anatomical location of that because of where the conduction system lies. And again, we'll go on to talk about that in the next few slides. This slide is just to further emphasize, especially when we're doing coronary artery surgery, to understand where the coronary arteries lie. They lie within the epicardial surface of the heart, so not the endocardial surface, the epicardial surface of the heart. But in some patients, they are intramyocardial, so deeper within the myocardium, and they make the vessels a little bit more difficult to find when we're performing coronary artery bypass grafting. But they're usually surrounded by this epicardial fat pad, and the vessels themselves usually protrude, allowing identification of the vessels. So where do we find these vessels? So again, it's important to have an understanding of the anatomy of the coronary circulation. So here we can see some very old diagrams of the heart by Frank Netter, but I think they're really good in terms of they describe where the coronary vessels are. And importantly, I wanted to try and impart on you, if there's one thing you remember from today's lectures, is that the coronary vessels lie in grooves in the heart. So again, if we think about the left coronary circulation, we've got the left main stem artery, which is usually very short, 1 to 4 centimeters in length, and then bifurcates early into its main branches. The left anterior descending artery, which descends on the anterior aspect of the heart, and hence its name, and the circumflex coronary artery. The left anterior descending artery lies in the anterior interventricular groove, and its anatomical name, actually, of the left anterior descending artery is actually the anterior interventricular artery because of its anatomical location. Similarly, we see the right coronary artery coming off from the right coronary sinus of the aortic root, and it lies in the right atrioventricular groove between the right atrium and right ventricle, so in the right atrioventricular groove. And similarly, if we rotate the heart, we'll see the circumflex coronary artery running into the left atrioventricular groove, giving off its obtuse marginal branches. And similarly, the right coronary artery at the back between the right atrium and the right ventricle in the right atrioventricular groove. And the last main artery that we often deal with as cardiac surgeons is the posterior interventricular artery, which lies in the posterior interventricular groove, the posterior aspect of the heart between the two ventricles. The posterior interventricular artery clinically is often called the posterior descending artery. But if you understand its anatomical name, you'll understand where it lies, between which structures it lies anatomically. Similarly, the venous structures which run with the arterial structures the major venous structures lie within the grooves and sulci. So here at the front of the heart, we have the great cardiac vein lying in the anterior interventricular groove. We have the coronary sinus, which is the main coronary venous drainage vessel that lies in the left atrioventricular groove. And we have the middle cardiac vein, which runs in the posterior interventricular groove. And in addition, we have the small cardiac vein, which runs a little bit on the acute margin, but also in the right atrioventricular groove. Trying to relate some of these structures that we see on these illustrations to what we would see in a pathological specimen, we can again see the right coronary artery lying between the right atrium and the right ventricle in the right atrioventricular groove, and the left anterior descending artery between the left ventricle and the right ventricle in the anterior interventricular groove, just to further illustrate that point. This anatomical dissection specimen also shows clearly some of the branches of the right coronary artery that we'll go on to talk about later. So some of the right ventricular branches, the conus branches, the acute marginal branch that runs across the acute margin, and also you'll just see the sinoatrial branch, but we'll go on to talk about those later. Apologies for the clarity of this image, but it tries what I'm trying to show on this illustration is the different segments of the left anterior descending artery, which again is useful when cardiologists try and describe where a lesion is for the surgeons to understand where to do the bypass graft. And so the left anterior descending artery is divided into a proximal part, a middle part, and a distal part. The proximal part is defined by the origin from the left main stem to where the first septal perforator comes off. The distal LAD is defined from where the terminal diagonal comes off and the remainder of the LAD up to the apex. And the bit in the middle is obviously between the proximal and distal parts. This illustration also tries to give you an idea of the different branches of the left anterior descending artery. And it's mainly diagonal branches which come off laterally. And there are usually 3 to 5, but this can vary anatomically. And then also the septal perforators, which come off perpendicular to the left anterior descending artery. And as per their name, they perforate the interventricular septum and perfuse blood to the interventricular septum, which is important when you have post-ischemic ventricular septal defects caused by myocardial infarction. And again, understanding the blood supply of this is very important. This diagram also illustrates after the short left main stem, the circumflex coronary artery coming off and giving off the obtuse marginal arteries. The names given because these arteries run across the obtuse margin of the heart, as opposed to the acute margin of the heart, which the branches come off from the right coronary artery. This video will further delineate exactly where the left coronary vessels come off. So you can see the left coronary artery, left main stem coming off the aortic root from the left coronary sinus, dividing into its 2 branches, the left anterior descending artery, or otherwise known as the anterior interventricular artery, and the circumflex coronary artery, which lies between the left atrium and the left ventricle, giving off these arrows, these obtuse marginal coronary arteries. Moving on to the right coronary artery, as mentioned earlier in the anatomical specimen I showed you, has many different branches which are important. So the sinoatrial artery that supplies the sinoatrial node in 55% of patients. It also gives off acute marginal branches which run across the acute margin of the heart. It gives off some small right ventricular branches, and then it divides at the crux into the posterior descending artery in patients with a right dominant circulation, and also a posterior left ventricular branch, which also gives off the artery to the atrioventricular node. In patients with a right dominant circulation, which is 85% of patients, the AV nodal artery comes from the right, as does the posterior descending artery. In the other 10 to 15%, or in the other 10% of patients, these vessels come off the circumflex coronary artery, and in 5% of patients, the circulations are co-dominant. Dominance is coronary artery dominance is defined by where the posterior descending coronary artery or the posterior interventricular artery comes off. And similarly here, we've got a video illustrating where the right coronary artery originates from. So here you can see in the right coronary sinus of the aortic root, it then runs down the right atrioventricular groove between the right atrium and the right ventricle. We can then see it running onto the posterior surface in the right atrioventricular groove, giving off in the majority of patients the posterior interventricular artery. This illustration talks about some of the coronary venous circulation. So here we can see some of the major coronary veins. So the great cardiac vein. And again, another take-home message is the main coronary veins run with the main coronary arteries, and they both run in the main sulci or grooves of the heart. So here we can see the great cardiac vein running in the anterior interventricular groove with the left anterior descending artery. Here we can see the middle cardiac vein running in the posterior interventricular groove with the posterior descending artery. Here we can see the small cardiac vein running in the right atrioventricular groove with the right coronary artery. And then the most important coronary vein is the coronary sinus, which runs in the left atrioventricular groove between the left atrium and left ventricle. It is a continuation of the great cardiac vein, which runs in the anterior interventricular groove and then a little bit into the left atrioventricular groove. And it changes its name into the coronary sinus when you have the oblique vein of Marshall or the oblique vein of the left atrium draining into it. And the great cardiac vein changes its name into the coronary sinus. This illustration is just a picture post coronary artery bypass grafting, and we can see a coronary saphenous vein graft bypassing the right coronary or probably the posterior descending artery, a saphenous vein graft attached to the ascending aorta going round onto the obtuse marginal, and then the left internal mammary artery attached to the left anterior descending artery. And just stressing the importance of understanding where these vessels lie anatomically before Mohammed Osman will talk to you about coronary artery bypass grafting surgery, but understanding the importance of anatomy and why that is relevant to when we're doing our surgical operations. I'm going to move on to talk about the conduction system, which is important because of its relation to some of the valvular structures and why when we put different sutures when doing valve repair or valve replacement surgery, why we need to avoid tissue, which is part of the important tissue, which is part of the conduction system. Cardiac activity is usually generated by the sinoatrial node, and I'll show you where that sits anatomically at the junction between the right atrium and the superior vena cava. It sends out signals that run across internodal pathways, including the Bachmann bundle in the atria, which then reach the atrioventricular node. The atrioventricular node can be found in the membranous septum beneath the commissure between the non and the left coronary, the non and the right coronary sinuses. It can also be found near the trigone when performing the mitral valve surgery, and I'll show you these structures on the next slide. Conduction from the atrioventricular node then runs along the bundle of His, and then down the left and right bundle branches, and then finally termination or contraction of the ventricle. And again, understanding where these pathways are will help you understand the morphology of an electrocardiogram. So the P wave, when you've got conduction across the atria, and then the QRS complex, when you've got conduction across the Purkinje fibers across the ventricular myocardium. And you can see the gap, the PR interval that exists between the two areas of depolarization when electrical activity is being conducted through the bundle of His and the bundle branches. And again, so here to understand the anatomical location of the sinoatrial node, we can see it sitting between the right atrium and the superior vena cava. It's sometimes in a crescent shape, or the majority of times in a crescent shape, but sometimes can be found in a horseshoe shape around that junction. And that's again important when we are operating in these areas, and particular for patients, for surgeons who perform a transseptal access to the mitral valve across the right atrium and then down into the left atrium. This is where sometimes either the node or the sinoatrial artery, if it is from a right dominant system, can be found and damaged or injured during this surgery. So it's again important to understand the anatomical location of these structures. Similarly, you want to understand where the atrioventricular node sits, and it's classically defined as at the apex of the tendon of the apex of the triangle of Koch, which is demarcated by the tendon of Todaro, the hinge point of the septal leaflet of the tricuspid valve, and also the coronary sinus. These three structures form the triangle of Koch, and at the apex of the triangle of Koch is where the atrioventricular node and the bundle of His lie. And again, it's important, and you'll see on one of my next slides of how we perform tricuspid valve surgery, why we need to avoid putting sutures in this area to avoid causing heart block and conduction delays. Next, we want to understand some of the cardiac valves. This is the illustration you saw earlier with the aortic valve lying at the center of the four valves, the tricuspid valve with its different structures, the mitral valve and the pulmonary valve. And understanding the anatomical interrelation between these valves is important because of, say, when performing mitral valve surgery, it's important to understand the proximity of the aortic valve in relation to the aortomitral curtain so that you do not damage the aortic valvular structures and don't cause any aortic regurgitation, for example. Here we see the different leaflets of the four different valves. This is the pulmonary valve with its anterior leaflet, right and left leaflets, the right and left coronary arteries in the aortic valve and the non-coronary sinus or non-coronary cusp of the aortic valve. Similarly, you've got the anterior and the posterior leaflets of the aortic valve. Some surgeons like to call this the aortic leaflet of the mitral valve, and this is the mural leaflet of the mitral valve. And then you've got three leaflets of the tricuspid valve. So you've got the anterior leaflet, the septal leaflet, and the posterior or the inferior leaflet of the tricuspid valve. You'll note that the mitral valve is the only valve of the heart that has two leaflets. The other valves have three leaflets, so tri-leaflet valves. Here's some operative illustrations of the aortic valve. You can see the three different leaflets, the left coronary cusp in the left coronary sinus giving off the left coronary artery. Similarly, the right coronary cusp in the right coronary sinus, and here you can see the right coronary artery coming off. And then the non-coronary cusp in the non-coronary sinus. You can see at the tips of these different leaflets, you've got the nodule of Aurantus, and which is just a thickening at the leaflet tips. And then you can see the difference between what is a tri-leaflet aortic valve, which is the normal structure, the normal anatomical structure of the valve, and what's here is a bicuspid aortic valve with fusion of the left and right coronary cusps, leaving a bicuspid aortic valve. Here you can see some pathological disease of this bicuspid aortic valve with extensive calcification and operative intervention on it, necessitating aortic valve replacement, which Kulvinder will talk to you in more detail about in a subsequent presentation. The anatomy of the conduction system and valvular surgery is very, very important. And here we can see again the atrioventricular node, the bundle of His, and the conduction fibers in their proximity to the different structures. So here, if you're performing mitral valve surgery, the proximity of the conduction system to the right fibrous trigone. When performing aortic valve surgery, the proximity of the conduction system to the aortic valve leaflets, and especially beneath the commissure between the right coronary cusp and the non-coronary cusp is where you'll find the conduction system. And again, if you end up performing myomectomies for patients with hypertrophic obstructive cardiomyopathy, this is where you resect some tissue, and it's important to appreciate where the conduction tissue is. And similarly, the understanding the interrelationship between the different valves. So you've got the anterior mitral valve leaflets, the aortomitral curtain and the proximity to the aortic valve, and especially the non and the left coronary cusps. And then you can see the interrelationship with the structures beneath the a mitral valve, the subvalvular apparatus, which we'll go on to talk about in a minute. So here is an operative illustration of the mitral valve, as we talked about the anterior mitral valve leaflet and the posterior mitral valve leaflet. As surgeons, we try and divide the posterior mitral valve leaflet into different scallops. So the P1 scallop, P2 scallop, and the P3 scallop, which are often subdivided by these different indentation or clefts. And this anatomical description of the different scallops of the posterior mitral valve leaflet is important because we want to because cardiologists are able to then convey to us the importance of where the different lesions are within the mitral valve. And similarly, there are corresponding scallops on the anterior mitral valve leaflet, A1, A2, and A3. The anterior and posterior mitral valve leaflets meet at the different commissures, the anterior lateral, the anterior medial commissure and the posterior lateral commissure. And in addition, you've got the proximity of the aortic valve with the aortomitral curtain and the left and non-coronary cusps. The importance of the subvalvular apparatus in mitral valve surgery is crucial because all these different parts are important on competency of the mitral valve. And the 5 different aspects of the mitral valve complex are the mitral valve annulus, the ring around the mitral valve itself, the anterior and posterior leaflets, the chordae tendineae, which attach to papillary muscles, which are part of the left ventricular muscle. So the 5 parts that contribute to competency of the mitral valve are the left ventricular muscle itself, the papillary muscles, the chordae tendineae, the leaflets, and the annulus itself. The chordae tendineae themselves are subdivided into primary, secondary, and tertiary chordae. The primary chordae that attach to the free edge, the secondary or strut chordae that attach to the main body of the leaflet, and then you have tertiary chordae, which sometimes attach to the ventricle itself or at the junction of where the leaflets attach to the annulus. This is the different structure of the tricuspid valve leaflet, the anterior, septal, and posterior leaflets. You can see the commissures between the different leaflets. And again, I was mentioning to you where the conduction system lies, which is why we use incomplete rings on the tricuspid leaflet, so not to damage this conduction system, the bundle of His and the bundle branches and the atrioventricular node when performing tricuspid valve surgery. And this again lies at the triangle of Koch, as you saw on an earlier structure. The tricuspid valve itself has similar subvalvular structures to the mitral valve, with the papillary muscles, the chordae tendineae, the leaflets themselves, and the tricuspid valve annulus around the structure. This illustration further delineates the important subvalvular apparatus of the mitral valve. So here we've got the mitral valve annulus here, the anterior and posterior mitral valve leaflets. And you can understand why this some surgeons call the aortic leaflet of the mitral valve because of its proximity to the aortic valve. And then again, the mural leaflet or posterior leaflet. Here we can see the subvalvular apparatus, the chordae tendineae attaching to the papillary muscle in the ventricle. And again here, chordae tendineae attaching to the papillary muscle, which attach to the ventricle. And here you can see it opening and closing in systole and diastole. So during systole, when the heart contracts, the muscle, the mitral valve closes, and similarly in diastole it opens. Here you can see the proximity of the other valves, the aortic valve with its 3 leaflets opening and closing. So it opens in systole to allow blood to leave the ventricle and closes in diastole. And the arrow showed the proximity of where the coronary arteries are, the right coronary artery, and in here, the left coronary artery. Just a brief overview of the pericardium. As mentioned earlier, the pericardium has got a fibrous and a serous pericardial layer. The serous pericardial layer is further subdivided into visceral and parietal layers, and between those two is where the pericardial fluid lies. So this is where the fibrous layer of the pericardium would be. The serous layer would be between the parietal outer and the visceral inner layer, and pericardial fluid lies in between. And between these pericardial layers is where the different sinuses lie. The transverse sinus, which lies anterior to the superior vena cava, posterior to the aorta and pulmonary trunk, and then just in front of the pulmonary veins. And then the oblique sinus lies on the posterior pericardium between the pericardial veins. And these structures are important, especially for transplant surgeons, but also to an understanding of when you're dissecting at the back of the heart. And then finally, to talk about the aorta. The aorta is subdivided into different parts. The aortic annulus, where it leaves the left ventricle, the sinotubular junction between the sinuses of the aorta and the aortic root, and the tube, the ascending aorta. So you've got the sinuses of Valsalva in the aortic root, and then the ascending aorta. So the aortic root is defined as the area between the aortic annulus and the sinotubular junction, and then where the ascending aorta lies. Beyond that is where the aortic arch lies, and that is defined by where the origin of the brachiocephalic or nominate artery is, and it finishes into the descending artery just beyond where the left subclavian artery is. The three main branches of the aortic arch are the nominate or brachiocephalic artery, the left common carotid artery, and the left subclavian artery. And here you can see how these different structures within the aortic root interact. So the different rings at the aortic annulus and at the sinotubular junction, and how the coronets or the crown-shaped attachments of the aortic valve allow different areas of the aortic wall to be within the left ventricular cavity, and different areas of the ventricular muscle to be within the aortic root. And it's important to have this understanding, especially for when doing valve-sparing aortic root operations. That is my brief overview of cardiac anatomy. As I said, getting a good understanding of cardiac and coronary anatomy is important for when performing the different operations as a cardiac surgeon. And hopefully you'll take on some of this information I've conveyed in the presentation this morning into some of the clinical talks that you will hear from my colleagues later this afternoon. And just to stress again, please, any questions that you've got related to this, please feel free to submit to us, and we'll try and tackle them later this afternoon. But once again, thank you for the opportunity to present to you, and I hope that's given you some insights into some of the clinical practice we'll hear later today. So thank you.
Good afternoon, ladies and gentlemen. My name is Muhammad Osman. I'm a senior clinical fellow at Royal Papworth Hospital. First of all, I'd like to thank the SCTS, Egyptian Society of Cardiothoracic Surgery, and Suez Canal University for giving me the opportunity to be here today. My first talk would be around about coronary artery disease from the surgical point of view. And later on in today, we'll have another session about operative aspect of coronary artery bypass graft surgery. I'm very happy to answer any questions after the presentation. I hope both presentation would be useful for people who's going to do the exam. Thank you very much. Hi, everybody. My name is Muhammad Osman. I'm a senior clinical fellow at Royal Papworth Hospital, Cambridge, UK. First of all, I'd like to thank the SCTS, Egyptian Society of Cardiothoracic Surgery, and Suez Canal University for giving me the opportunity to present in this meeting. In this session, I'm going to talk about the coronary artery disease from the surgeon's point of view. I have no conflict of interest. Just to mention that illustrations in this presentation are taken from key questions in cardiac surgery. I'll start my presentation with the pathology of atherosclerosis. Atherosclerosis is a Greek word. Athero means paste and sclerosis means hardened. So the process of atherosclerosis starts with endothelial damage or endothelial dysfunction with a decrease in NO secretions. Then the foam cells, which is a macrophages engulfing lipids, start to invade the vessel. The second stage, or the early lesion, is characterized by formation of the fatty streak. So the fats become also extracellular, and the migration and proliferation of vascular smooth muscle cells. Then the formation of what's called vulnerable plaque. In this stage, there is a thin fibrous cap, which is very liable to rupture and bleeding and overtop thrombosis. The next stage is the advanced lesion or the atheroma, which might be a need for platelets aggregation and thrombus formation. Risk factors for coronary artery disease are classified into modifiable and non-modifiable. The modifiables ones we can control, like diet, smoking, hypertension, dyslipidemia, diabetes, obesity, high calorie intake, physical inactivity, and psychological stress. While the others, we can't control them, as the advanced age, genetic predisposition, family history, and male gender. The clinical picture of coronary artery disease, the classic picture is the angina pectoris, which is defined as a pain caused by myocardial ischemia due to coronary stenosis. And as any ischemia, it's a demand-supply mismatch. This also might be caused by tachycardia, anemia, aortic stenosis, syndrome X, where there's a chest pain, or angina pectoris without any coronary stenosis. Prinzmetal angina also is a cause which is due to coronary spasm. The characters of the angina pectoris is a deep, diffusely distributed central chest pain. So when you ask your patient to point on the pain, he couldn't. The pain is diffusely distributed over the chest. It also not sharp pain, and here we have to be careful differentiating between the sharp and severe pain. Usually it doesn't last long, 1 to 5 minutes, never over an hour. And if it's going to respond to the GTN, the response would be immediate. We have to be very careful in taking history, especially with diabetic patients. So angina might present with dyspnea, fatigue, recurrent belching. That also suggests ischemia. The angina is classified into stable and unstable angina. Stable angina is the pain which is comes with effort and released by pain or GTN, and it's predictable. Unstable angina, which is increase in frequency or severity, or when the patient has angina at rest. Another term to be aware of is the acute coronary syndrome. Acute coronary syndrome is a term used to describe acute coronary ischemia. It's subdivided into 3 categories: unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. For the unstable angina, there is no ST elevation and there is no enzyme rise. This is to differentiate it from the non-STEMI. With the ST elevation myocardial enzymes, you will find both. When the patient is referred to us as a surgeon for a coronary artery bypass graft surgery, we have to be very careful taking a history from the patient. We ask about the recent myocardial infarction, time, how it was managed, and when was the last myocardial infarction. Any previous cardiac or thoracic surgery or chest radiation. We also ask about any condition predisposing to bleeding or any contraindication for anticoagulation. This is going to change our plan, either surgical plan or post-operative plan. Any renal dysfunction, cerebrovascular disease or carotid bruit should be also investigation. Any electrolyte disturbance that might to predispose for post-operative dysrhythmia also should be included. Infection should be excluded before elective surgeries. Any respiratory dysfunction, and if we need to send the patient for pulmonary function test, we'll do before the surgery. And we have to take careful history to evaluate the availability of conduits for CABG. This history should include any previous varicose surgery or legs surgery. We investigate our patients as a routine preoperative investigation, full blood count, hemoglobin, any anemia should be investigated and treated before the surgery. Any platelets dysfunction or a low platelet count should also be investigated and treated before the surgery. We have to have full clotting screen before the surgery. Kidney and liver function tests are also mandatory. Screening for MRSA is also mandatory before the surgery. In the chest X-ray, we check for cardiomegaly, calcified aorta, or any lung pathology. Please, if you are suspecting a porcelain or calcified aorta, send your patient for a CT scan, because that might change your surgical strategy. ECG looking for previous myocardial infarction or any hypertrophy or arrhythmia. Echocardiography is mandatory before coronary artery bypass surgery, and we are going to discuss this in the next slide. So for any patient is going for a coronary artery bypass surgery, we do an echo to check the function, the regional wall motion abnormality, and the valvular lesion. If you have dyskinesia or akinesia, you have to investigate for viability of this segment, and is the patient going to get benefit from the surgery or not. And for the valvular lesion, you have to decide pre-operative, are you going to do something for the valve, or this patient just needs coronary artery bypass graft surgery. We'll go through this in more details in the next slides with the guidelines. Coronary angiogram is one of the most important investigations before coronary artery bypass graft surgery. As a surgeon, we see coronary angiogram very frequently. So I'm just going through understand the coronary angiogram. So there are two angulation, right or left, and cranial or caudal. When we refer to right angulation, right anterior oblique, we mean that the detectors is on the right hand side of the patient. And when we say it's on the left anterior obliques, that means that the detectors is on the left hand side of the patient. Cranial angulation, that means that the detectors are at the patient's head, while caudal, that means that the detectors towards the patient's foot. There are general rules to interpret coronary angiogram. So the left anterior descending artery, that the artery that descends toward the apex, usually the longest vessel in the angiogram, and it has septal perforating coming off at 90 degrees. The circumflex artery is the artery which is closest to the thoracic spine and the descending aorta. If the angiogram through his femoral artery, you can see the catheter in the descending aorta. There are 5 standard views to view the left coronary system, and there are 2 standard views for the right coronary system. For the left, right anterior oblique caudal, epicaudal and cranial, left anterior oblique caudal and cranial. For the right system, you have left anterior oblique and right anterior oblique. To identify the angiogram view, there are some rules. usually the spine is on the opposite side of the view name. For example, if you can see the spine on the left-hand side, so that would be right anterior oblique. Sometimes you couldn't see the spine in the view. In this case, you check for the ribs direction. So the rib directions go from up to down at the same direction of the view. So in the right anterior oblique, you will find the spine on the left-hand side, as here, and the rib direction going to the right-hand side. So this is right anterior oblique view for the left system, which shows the left main, the circumflex artery, and the LAD. This view is good to see the circumflex artery all through. And here the angulation is caudal angulation. So right anterior oblique with caudal angulation. So this is again the left system with the AP view, caudal and cranial. So we can see clearly the left main coronary artery and the LAD going through here with one of the septal perforator branches. And this is the catheter there. Again, that's the catheter, left main, circumflex. AP caudal is good to see for its AP caudal is good for you to see the wall circumflex, and AP cranial, it's good to see the wall length of the left main coronary artery. Here in this view, we can see the diaphragm. Usually we ask the patient to take breath, but sometimes the diaphragms come in the view, especially in the cranial view. That's here the diaphragm. Just to simplify the view, it looks like a Christmas tree. So then the left anterior oblique with cranial angulation and the left anterior oblique with caudal angulation, or the spider view. The left anterior oblique with the cranial angulations brings the LAD on the midline, and it's good view to see the wall length of the LAD. Here again, the spine on the right-hand side, because this is a left anterior oblique, or if we can see we know that the catheter here is coming from the femoral, so in the descending aorta. For the left anterior oblique, the caudal or the spider view, it's a very good view to see the left main. Again, it looks like a spider. That's what the cardiologist, and if this looks like a spider, I'd like to call this the grape pile. It looks like a grape pile for people who like to remember things for the exam. The right coronary artery, we have two views, the left anterior oblique and the right anterior oblique. So, and it's very easy to differentiate here, the spine on the right side, the right-hand side, so it's a left anterior oblique. Here, the spine is clearly on the left-hand side, so this is a right anterior oblique view. And with the right anterior oblique, we extend the PDA to see any lesion. It's advisable to see the lesion in two views, not on only one view. Here are all the 5 views for the left system. Next step, we go for the management of coronary artery disease. So management of coronary artery disease depends on the stage, the symptoms, and the risk factors of the patients. If the patient has a risk factor for coronary artery disease, we start off preventive measures like diet control, stop smoking, and increase exercise. If the patient on a higher risk of coronary artery disease, we might need to add some preventive measures like aspirin, statins, and ACE inhibitors, in addition to the control of the risk factors. But if once the patient starts having symptoms, in addition to the previous measure, we're going to add anti-ischemic measures in the form of beta blockers, GTN, and reperfusion therapy. And if the patient had acute coronary syndrome, we have to add to all the other measures, again, antithrombotic therapy. Now let's go to the important bit, for us as surgeons, which are the indication of surgery in ischemic heart disease. I'll start with this diagram from the guidelines. So which patient favors the coronary artery bypass graft surgery? So CABG patients with diabetes will get benefit from the CBG rather than the PCI. Patients with decreased LV function, giving in mind the risk factor would be low. If there is a contraindication for dual antiplatelets therapy, these patients will benefit more from coronary artery bypass graft surgery. And if there is a recurrent diffuse in-stent restenosis, so this group of patients also will benefit more from the bypass surgery rather than having another PCI. From the anatomical point of view, the multivessel disease with a syntax score more than 23 is favorable for surgery than the PCI. Also, if the patient has a severely calcified coronary artery that might limit full expansion of the artery using the PCI, this patient will benefit more from surgery. Patients with lesions that are unlikely to be fully revascularized with the PCI should be referred to surgery as well. And if the patient has another concomitant valvular or needs another cardiac surgery, this group of patients usually get benefit from surgery rather than having a PCI. Now let's go for the indication of coronary artery bypass surgery. We'll start with the patients with a low risk surgical mortality. And for the sake of time, I'm just going through only class 1 indication. So patients with proximal LAD stenosis with a one vessel disease are indicated for coronary artery bypass graft surgery. Also, patients with two vessels disease include proximal LAD stenosis. All types of left main are suitable for coronary artery bypass graft surgery. I'm not going in this session with a debate about left main disease, either surgery and the syntax score or a PCI. This is not the subject of this presentation. Patients with three vessel disease, either diabetic or not diabetics, are all indication for cardiac surgery, and they are all class 1 indication for cardiac surgery. Then the indication of cardiac surgery in special circumstances. I would start with patient who has combined coronary and valvular disease. If the patient going for a valve surgery as an AVR or mitral surgery who has a coronary lesion more than 70%, this patient should have bypass surgery in the same setting. If our patient is going for coronary artery disease and has severe aortic stenosis or severe functional mitral regurg with ejection fraction more than 30%, they should have their valvular surgery done at the same session. With patients with ejection fraction less than 35% are indicated for cardiac surgery, given the fact that their risk would be a low surgical risk. Coronary artery bypass graft surgery is indicated in the patient with a cardiogenic shock as a class 1 if there is no other PCI option. There are many factors that affect the choice of conduit for coronary artery bypass graft surgery. Age is one of them. In young patients, we do prefer to give them more arterial grafts. Risk of sternal infection is another factor. For a patient who had a COPD or immunosuppressed, we usually try to avoid taking bilateral mammary artery to reduce the risk of sternal wound infection. Availability of a conduit is very important. For example, if a patient has a varicose vein or had stripping for the veins for any reason, we can't use the saphenous vein graft. Urgency of operation may play a role. For example, if you have an emergency crushed patient, it's preferred to use veins and rather than using the mammaries. Patient with diabetes mellitus, either to use skeletonized mammary or to use the mammary on one side only. Patient's preference also should be involved in the decision making. Some patients would dislike a scar on their forearm when using the radial artery. And also the degree of stenosis. To use the radial artery, we have to put this artery on a high degree of stenosis to get the best results. surgeon's experience also a factor. Now I'm going quickly to discuss the advantages and disadvantages of each graft. So for the long saphenous vein graft, it has an 80% 10 years patency. It's available conduit, but on the other hand, as I mentioned, we can't use it if there's a severe form of varicose veins. The left internal mammary artery is a superior graft, has a 95% 10 years patency, but again, when we use pedicled left internal mammary artery, the risk of sternal wound infection is higher. Right internal mammary artery has 90% 10 years patency, but again, sternal wound infection is a risk. The radial artery, the 10 years patency is 80%. The disadvantage is the spasm. It's very liable to spasm and scar. As I mentioned, some patients would not like the arm scar. Before taking the radial artery, we usually do the Allen test in the clinic, and I'd advise to do what's called intraoperative modified Allen test. Simply after dissecting the radial artery, we ask our anesthetist to put a pulse oximeter on the same hand that we're going to harvest the radial artery, and simply after dissecting the radial artery, we put a bulldog on the radial artery and watch for the pulse oximeter. In this slide, I'm going to quickly review the guidelines, the class 1 guidelines for choice of conduit. The guidelines recommend using the Lima to LAD. It also recommends using the radial artery on a high degree stenosis over the vein graft. And it recommends using the skeletonized mammary if there's a high risk of sternal wound infection. Thank you for watching my presentation. I'd like to thank the SCTS, Egyptian Society of Cardiothoracic Surgery, and Suez Canal University for giving me the opportunity to present in this meeting.
Great, thank you very much. Many thanks to Suez Canal University, the Egyptian Society, and to the Society of for Cardiothoracic Surgeons for Great Britain and Ireland for asking me to talk. And the title of my talk today is Aortic Valve Disease. And I'll give you a quick rundown of current practices in the UK and Europe and America, and mainly focus on aortic stenosis. My name is Kulwinder Lal. I'm a consultant and lead cardiac surgeon at the Barts Heart Centre in the UK. So I work at St. Bartholomew's Hospital in London, which was originally founded in 1123 by a monk called Rahir, who was a courtier of Henry I. And our hospital was refounded in 1546 by Henry VIII, who signed the first agreement